Hello everyone, welcome to our healthcare webinar organized by ERNs. So my name is Andrea Zembrero, I'm part of the ERN and healthcare team of ERNs, and I will use these first 5 minutes to give you an overview of today's webinar while everyone is joining. So today's webinar will address care pathways and more concretely the added value of patient involvement in the design of care pathways. So we will do that through an introduction to care pathways, and also we will have the opportunity to hear from best practices, methodologies for care pathways development. We'll have patient leaders from the rare disease communities that will share their real experiences. And in this webinar, we will identify recommendations that will be used in the development of ERN care pathways under JARDIN. So more concretely in the agenda, we'll have first an introduction to care pathways from Matt Johnson from ERNs. Then we'll have presentations from best practices examples. So first we'll have Bradley Price, Director of Policy and Public Affairs at Action for Pulmonary Fibrosis, that will present a disease-specific care pathway. Then we'll have Vicky McGrath with CEO from Rare Disease Ireland that will present a national care pathway. And then we'll have Ilaria Galetti from the Italian Systemic Sclerosis Organizations and ERN Reconnect TPAC advocate that will present a European pathway experience, her European pathway experience. So we'll have the 3 examples, and then we'll have time for a panel discussion where best practices will explore, and also the challenges and key recommendations. Then we'll have time for questions and answers, but don't hesitate to jump into the chat also and share your questions. So for this session, please don't forget to mute your microphones, and then it's always nice to see your faces when you are, especially for the question and answer time, to see your faces. And well, I hope that you will enjoy this webinar on care pathways. So I think that we have already a good number of participants. At the end of the webinar, we will also share a survey, a satisfaction survey, so please don't forget to fill it. So now I give you the floor to Matt Johnson from ERNs that will give this introduction to care pathways.
Super, thanks a lot, Andrea, and I will be quick because I would like us to get on to the main event, which is hearing from Bradley, Iliara and Vicky. I think their experiences are more interesting than the background stuff I'll be covering, but I'll cover this stuff quickly just so we're all on the same page. So when it comes to healthcare services, we want them to optimize and meet the needs of our community, and a lot of the time they need to be redesigned and developed. And there's a number of tools which are used to develop health services locally. These can be care standards, clinical decision support tools, clinical guidelines, and also patient journeys, care pathways and model pathways. And what I want to do today is just to set out really what these different tools are for, so we can then have an informed discussion around care pathways and where patient representatives should be involved. So the definition, the difference between a patient journey, clinical guidelines and a patient pathway or care pathway is that patient journeys chart the needs of patients for a specific condition and also their experiences. It outlines what their needs are, what would have been really helpful to have in terms of support, and what would be best practice. These tools can be used to enhance communication between patients, families, members, and with healthcare providers, and give a clear direction of the journey ahead. Clinical guidelines are statements that include recommendations intended to optimize patient care that are informed by a systematic review of the evidence and an assessment of the benefits and harms of alternative care options. Patient pathways or care pathways are different than patient journeys. Their pathways are more based on their multi-professional tools that summarize the clinical guidelines. They put them all together and they put those guidelines into practice, and they detail what happens when and by whom is responsible for each of the different activities in that pathway, and they aim to optimize care and treatment for a specific population. But these pathways can vary in granularity. They can be quite high level or they can be more detailed. So the different types of pathways, there's lots of language which is used. We hear about clinical pathways, patient pathways, care pathways, modeled pathways. So the differences are, these are the different levels of granularity. Clinical pathways are really developed for use in a specific clinic or department, whereas a care pathway or a patient pathway, they can be used interchangeably. They're much longer in duration, and they encompass different stages of the pathway from first presentation through to diagnosis, treatment, and follow-up. A modeled pathway is actually something which is more of a reference point. It summarizes the key evidence, but it's not tailored to a specific system. So therefore, a model pathway which could be developed at a European level can be taken and tailored into in it to inform local pathways and how they're developed. Because care pathways are developed on by pulling together the existing evidence, the guidelines which are produced, we all know that in guideline development, there's international best practice called grade and agree. Grade is used to grade the evidence for its robustness and its strength of evidence to build guidelines on, and agree is used retrospectively once a guideline's been developed to check whether it's good quality and independent, and in its nature, how it's being developed is not is independent and you can rely on it. But when it comes to developing care pathways, there's not one single methodology. There's not the equivalent of grade and agree. And in many ways, you are using the existing guidelines, which are using that international best practice, but there's not one process. So I've mapped here an overview of the key phases to develop a pathway based on reviewing 5 different methodologies, some in the ERNs and some international. So phase 1 is the preparation stage, which is around identifying needs, the need for a pathway to be developed, establishing the governance process in place, setting up the project team or the core team with the chair and experts involved, and they're responsible for how we develop the pathway. The scoping phase is more, once you've identified a pathway to be developed, you have to scope out what that pathway should cover. Should it cover the whole? Should it be from diagnosis through to long-term follow-up? Should it be just from diagnosis through to treatment? What's the patient population it's affecting? Is it for all people with a condition, or is it for younger people and young people and adult children? And also set out some parameters which the pathway should cover, including what we call key performance indicators. Once you've developed the pathway and it's implemented, what do you see the pathway benefit to being? And defining those KPIs, because when you get to implementation in evaluation, you'll be using those KPIs to check the pathway is doing the job it should be. In this scoping phase, this is where we really draw on what's already there and existing. So doing a systematic review to identify any publications and evidence, drawing on existing guidelines which have been developed, also mapping what the current pathway looks like. And it could be pathways in different countries, but seeing what the current state pathways, how they're structured, and then collecting the views of patients and their families on their needs and experiences going through the existing pathway and identifying where the bottlenecks are in accessing diagnosis or care and treatment. So that's the scoping phase. And then the development phase draws on all that material and it designs an ideal pathway, including red flags based on the evidence. You also building on the existing pathways, but taking into consideration the experiences patients have had going through that pathway, and try to redesign those bottlenecks so you can remove them. And once that's been reviewed and signed off, then we can move to the implementation. And you want to pilot the pathway, evaluate it in an ongoing manner. And I think there needs to be a clear feedback loop, because you need to make adjustments to that pathway on an ongoing basis. So we keep this should keep the pathway alive and should enable that we have a pathway which remains based on the evidence, but meets the needs of people on the ground. Why are we doing this webinar? Under Work Package 6 of the Joint Action on Integration of ERNs into Healthcare System, there's a work package on national care pathways. And in this work package, we are looking at developing a number of pathways, let's say 10 to 12, working with the ERNs. So JARDIN is, or the Joint Action is there to take existing assets or material from the ERNs and support implementation locally. Not many ERNs have developed care pathways, so we first of all have to develop some modelled care pathways. We'll be working with the patient community to map the needs of the community and to ensure that and working with the clinicians in the ERNs as well to develop those pathways. And then part of this work package is to implement them. The first bit we're going to be doing is looking at and reviewing the methodology for care pathways and looking at where patient representatives should be involved. Where is it added value? And that's the nature of this webinar. We'll be hearing from Bradley, from Ilyara and Vicky about their experiences, what worked well, what didn't, what are the challenges they faced and what recommendations. So we'll draw from this webinar to advise and inform the methodology used in this work package. After we've worked on the methodology, we'll develop a toolkit to support patient groups to be involved in those different activities, which we'll hear today, to support them in the process in the next couple of years. And then we'll work with those groups to map the needs and support the co-creation of these pathways with the ERNs. I'm going to stop there. The toolkit will be covering a number of activities, but I won't go into that now. But I will pass over now to, I think, Bradley. Oh, there's some questions. Is there any immediate questions before we move? I'm looking at you, Ines. Is there any
No questions? Go ahead.
Okay, so we'll move on to maybe a presentation by Bradley. We've got 3 presentations, all about 10 minutes long, where we learn from real world cases. So I'm going to hand over to Bradley.
Great, thank you very much, Matthew. I'll just get this up and running. Hopefully that's all looking okay for you, although my presenter view has conveniently disappeared. So if you give me 1 second. I will try to get that sorted. There we go. Right. Hi, everyone. Sorry about that. So my name is Bradley. I'm the Director of Policy and Public Affairs at Action for Pulmonary Fibrosis. I'm going to talk to you about the National Consensus Integrated Care Pathway that we've created for adults with interstitial lung disease in England. We have devolved health responsibilities in the UK for Wales, Northern Ireland and Scotland, and we are mapping how this fits onto those other systems as well. But for now, this is just looking at England. Very briefly about Action for Pulmonary Fibrosis, we are a national charity that looks to bring together people to drive change, to help people with PF to live well for longer. We make sure that patients, people with lived experience, clinical professionals are all at the heart of everything that we do, and hopefully you'll see that throughout this presentation. We've just released our new strategy. I don't think it's quite public facing yet. There's a little bit on the website about it, but these are our 4 priorities for the next 5 years. So you'll see that a lot today about how we are united to drive change, and that we want equitable access to evidence-based care and treatment for everyone, no matter where they live or who they are. So we've heard from people with experience of pulmonary fibrosis, a terminal lung condition characterized by the scarring of the lung tissue and the stiffening and smaller nature of the lungs, which makes it difficult to breathe. That they had all these issues where they lived around the country. So there was unwarranted variation where they lived, had a significant impact on their diagnosis, how quick it was for them to get treatment, for them to move from primary care to secondary care to specialist centres where they can get access to antifibrotic treatment, which are essential for those who are eligible to slow the progression of the disease. There is no cure for it at the time being. We know that people were facing slow and inaccurate diagnosis, but also they had lots of misdiagnoses for other respiratory conditions like COPD and asthma and bronchiectasis, which can look somewhat similar, but really shouldn't be happening a lot of the time. We knew that there were poor access to support services, so things like oxygen therapy, pulmonary rehabilitation, the things that sit around the interventional treatment that actually make an enormous difference to people's lives. They weren't able to access them if they lived in certain parts of the country. They had long waits for treatments, although antifibrotics, once you get to a specialist centre, you should be able to get them fairly quickly. In some areas, you still had to wait 11 months, and for a disease which can have, in the most severe cases, 3-year survival rate, that's not really very acceptable at all. And then people really struggle to move between the different parts of the system. Unfortunately, when you try and take this to the national bodies that have, the ability to make change, they don't always listen, or they don't always see it as a huge problem that needs sorting. So how do we want to do that, and how do we want to bring this lived experience voice into our policy making? So the first thing was, we had this anecdotal evidence, but we wanted to build a stronger picture. So the first thing we did was to create a patient survey, which I'll come on to build that picture and make sure that we can show around the country that there are shared issues, but also that there is an enormous amount of variation in access to care. We have co-creation of solutions with people with their own personal experience of these things to develop the solutions to the problems that they're facing, which you'll see through the pathway. And then beyond this, we need to make sure that we can bring them in for the influencing and delivery of these systems. So building relationships with senior decision makers, creating these cases for change, and making sure that things do, once we've got a solution, that they actually make it happen. So I wanted to talk a little bit briefly about who we need to work with here. So there are some key decision makers for specialised respiratory care in the UK and in England, specifically here. So you can see them all. I'm not going to list them off here, but you need to make sure that you have your priorities aligned before you get going with these pathways. Make sure that whatever you're doing can fit into the healthcare system, that follows the direction of travel that the National Medical Director or the National Health Service might be following, and try and follow alongside that and bring in these important parties, maybe within government, to help drive this along as well. So you really need to ask, who has the power to make this change? What are their priorities? How can you align their interests with yours and make sure that you're working together? Who else shares these priorities? So I've got here a number of other charities within the UK that we've worked with in building this pathway. And then how can you build the strongest possible case to invite change? So we did this survey. I wish it was cancer. I realize that's a very strong statement, but this is a direct quote, as you can see on the left-hand side of the screen, that someone said to us, and it was very powerful in this process. And it showed for the first time this postcode lottery of care, that people weren't getting access to the information they needed. So what we did was we held workshops across every region of England, as well as in Northern Ireland, Scotland and Wales, which you can see by the different colours in the map there on the fancy looking iPad graphic. And we also held an anonymous online survey to get care, as well as a paper version for people who were less digitally able. And then we've prioritised one-to-one interviews with diverse voices for a range of protected characteristics to make sure that we're getting as much information from a diverse range of views as possible. What we came out with these key themes, and there are a number of these. that really can only happen with serious transformational system change. That's not education for healthcare professionals. That's not trying to make minor changes. That's really trying to redesign the system. So we created this group called One Voice ILD, and it brings together all stakeholders interested in improving ILD care, and it's driven by patient, healthcare professional, commissioner, all kinds of input. And what we're focusing on is a transformational change, meaning that 5 years from now, someone could fall asleep, wake up, and then they would say, this is remarkably different from the current system. So onto the pathway, and sorry for the long context, but I think it's important in making sure that what you're doing is driven by the patient voice. We brought together a stakeholder group of people, you can see down the left-hand side, most importantly, those with lived experience. Finding these expert expert patients can often be hard. Commissioning changes are very complex, and most people quite rightly stay away from them. But finding those people to be able to help us to incorporate patient voice and drive this change from the patient experience was essential, as well as the healthcare and commissioning people that you can see. We used the data that we'd built from the I Wish It Was Cancer report to demonstrate the unmet need. We also needed to make sure, because money and resources scarce within the National Health Service, that we were demonstrating efficiencies and that this could be done maybe by reorganisation, but not with a significant amount of extra money from the system. And the NHS said that they weren't able to do this themselves, so we had to step in and fill it. But by doing that, we had to engage the senior external stakeholders like the National Medical Director, like the senior groups within the NHS, to make sure we were following what they wanted, as I previously said. And what we've ended up with here is the Interstitial Lung Disease Care Pathway. I will post links to this afterwards, so please don't scramble to take a shot of the QR code for now. And we wanted to redesign the system using the existing infrastructure, but making it better for people to have access closer to home, to have better capacity within the specialist centres who are massively overprescribed and very limited on resource. So what we did was add in an extra tier of care. So as well as having your local centres, your local respiratory centres, your local hospitals, we've created a prescribing centre that sits in between. So while you might have to travel to one of the 23 specialist centres in England to get your care right now, what would be better for patients and for the clinicians and give them more capacity would be to have centres closer to the patient's home, so that people who have pulmonary fibrosis, which can be quite a debilitating disease, you require a lot of oxygen, you're often not as mobile as you might be, then you can get to these centres, get access to the drugs, get access to this extra expertise, and upskill those centres to be able to do it. And the pathway looks a bit like this, and there's two areas that I really wanted to point out to you that will look different. One is that extra tier in the middle. So we're moving from a specialist centre approach to a regional approach to care, which was the priority of the senior NHS groups as well. And instead of having the standalone centres where everyone would have to go to get their treatment, there's now there's plans for co-working within regions, so that all of the different centres are working together. There's specialist input from the current specialist centres to help with diagnostics and management plans, but then patients can be treated in their local centre a lot more easily, along with the shared care for other comorbid diagnoses that can often be associated with ILD. The other thing that I really wanted to touch on was the shared care, because currently we know that people aren't getting access to the care that they need, and it's never really been mapped out exactly what should be given. So we're supporting regions and the centres themselves and the community respiratory teams to understand what services should be on offer, when patients and people experiencing pulmonary fibrosis should have access to them, but how they can understand the gaps in their current systems at the moment and try and fill them. So we're supporting them with business cases, whether that's around providing better services or increasing their capacity as centres. I will also say that this is a long-term vision. We are looking 5, 7, 10 years before we can get this fully implemented, but we've already taken significant steps to make it happen. So I'm almost out of time. So what are we doing next? We are strengthening the community. We're bringing everyone together and speaking with that one voice, trying to really push this case for change. We're helping with the business planning and business cases so that the centres that need extra capacity to fulfil the pathway that we've created are able to put in extra time for nursing, pharmacy, pulmonary rehabilitation, that kind of thing, to make sure they can do what they can, understand their demand as well. We're supporting decision makers nationally, regionally, and locally to be able to implement these changes. So making sure that the national commissioning guidelines are in place, making sure that the regions are considering where these extra centres might be going, and then helping the implementation of it on the local basis. And then trying to proactively influence as well. So making sure that we're talking to the right people with the ability to make change and keep moving this forward where possible. And apologies for the whistle-stop tour on that, but I'm happy to discuss it in the panel discussion. So thank you very much for listening.
Thank you, Bradley. That is really impressive, and you know, that's a patient group leading the way, saying there's a need here to initiate the development of a pathway and bringing being the focal point to bringing all those other experts together. I think it's a really, I said these are best practice examples, and I think it's clear why I asked you to join. So thank you very much. We'll come to some questions in a minute. I invite Vicky to maybe talk more about the approach that you've taken in Ireland around rare disease pathways, more from a national perspective, for not one condition but from multiple conditions.
Thank you very much, Matt. Yeah, so I'm Vicky McGrath, I'm the Chief Executive at Rare Diseases Ireland, and we are the National Alliance for Rare Disease Patient Organisation. So unlike Matt, I guess we're not doing a deep dive ourselves into individual diseases and pathways, but more supporting, I guess, the overall system for development of pathways. Let's see if I can get this to... you can see my screen, I hope. Yeah. Okay. Thank you, Matt. Okay. So I guess pathways in Ireland are there are none. Let's be honest about it. They're few and far between in the rare disease space. There might be a handful for a couple of rare diseases, but really, largely speaking, there are none. So back in 2020, we initiated a project with the National Rare Diseases Office here in Ireland, which is, I guess, primarily an information gathering hub, bringing together, I guess, or identifying expertise around the country and making sure that information is made available. It's not I guess, National Rare Diseases Office doesn't provide a clinical service per se. But in conjunction with the National Rare Diseases Office, it was recognised that we need to think about developing care pathways for rare diseases. As Matt has very eloquently put, the postcode lottery, I guess, as it's often termed, in terms of accessing the right diagnosis, the right care, the right expertise, is prevalent in Ireland. Depending upon where in the country you're living and what clinicians you're seeing, you may or may not get access to the best care. And so we want to try and, I guess, level that playing field. It was really, I guess, a project to try and level that playing field across rare diseases. So rather than taking a deep dive into one individual disease, we actually looked at, I think it's about 28 or 30 different diseases. So this is just a quick listing of the diseases that have been, I guess, looked into over the last 4 years or so. So the reasoning to do this really is to, I guess, put in place some logical document, some logical thought process around how patients should be diagnosed and how their care should be managed on an ongoing basis, to make sure that it is uniform across the country. So we have a very, I guess, Dublin-centric healthcare system. Most rare disease patients will find that their expert is located in Dublin. Occasionally, there might be an expert somewhere else in the country. And actually, we will find that for about 30% of patients say that there is no expert in Ireland. And that's just the nature of being a small country, that we just don't have, I guess, the consultant pool that maybe other countries would have. And so it's trying to make sure that that level of expertise is spread across the country, and that patients are getting access to the experts that they needed in the expert care. The pathways are also seen as being a tool to enable advocacy, to provide us, I guess, with a document that is approved at a national level by the healthcare service, that will actually, I guess, demonstrate that, you know, as a healthcare service, we are saying that we need these types of systems, we need these types of supports in place, that personnel need to be made available to individuals living with these diagnoses. You know, I guess it's not just something for guiding the healthcare system, it's also for ensuring that the healthcare system lives up to the expectations of the patient community. In terms of developing the national these rare disease pathways, the project has been led through our National Rare Diseases Office, through people there, and we have worked, Rare Diseases Ireland, we've worked very closely with the National Rare Diseases Office to, I guess, identify pathways and select the pathways for inclusion. Once we had that list of pathways, so the 30 plus that were that we showed earlier on, or that I showed earlier on, it was then obviously, as a national alliance, we don't have the expertise, we don't have the manpower either to get involved in 30 different rare disease pathways. So at that stage, it was creating that link into the individual patient organizations, where an organization might have existed, or the individuals even that maybe had kind of, I guess, it historically come forward as being interested, but maybe hadn't established an organization per se. Many of the organizations here in Ireland would maybe be a kind of a subset, maybe of a UK organization. So we have, I guess, lots of variations on the theme in terms of the types of patient organizations and the setup that each individual organization took. And I'd be happy to expand on that. You know, you're talking about 1 or 2 people for some of these diseases, and then, you know, large groups of people with well-funded organizations for other diseases. So it's really, I guess, the scale of rare disease or patient organizations that I think we're all aware of. Obviously, the clinical leads, we needed some type of expertise in Ireland. We'll be looking to the ERNs, I guess, to fill some of that into the future with additional pathways, but certainly clinical expertise available in Ireland to help develop these pathways. And then finally, obviously, you know, a pathway is from the patient perspective, it's the lived experience. It is every part of that care journey. What we have found is that much of the focus in Ireland definitely is on hospital-based care. That's the way our healthcare system has historically been set up. We're trying to transition to more, we're in I guess, in the process of transitioning to a more community-based centered care. But it's a journey that's ongoing. So we're trying to, I guess, future-proof some of these care pathways that we've thought about. What is the community setup that we need for these pathways to be delivered? So in terms of the patient organizations and the people living with rare diseases, so the expert opinion, you know, is the diagnosis and care suitable? Is it, you know, is there stuff going into these pathways that a clinician would say, okay, we need this type of information in a pathway, but actually doesn't really translate into the lived experience, or I guess, you know, the understanding, the capabilities of people living with these rare diseases and maybe their family members to get their heads around. So these, you know, these pathways aren't just, as I said, you know, an internal clinical tool or an internal health management tool. They are also intended to be tools for you know, people with the lived experience or people that are coming in with a new diagnosis. Obviously, from the patient perspective, there's other supports and resources. You know, when you're living with a rare disease, as we all know, you're 24/7 with it. You're 24/7 looking for those nuggets of information that have actually made a difference in your life. And so, you know, to try and gather some of that information into these pathways as well, to ensure that the next people that are coming along with the diagnosis don't have, I guess, that long journey to find those nuggets of information, that maybe they can be presented with them earlier following a diagnosis. And any other then kind of like general pieces of information around the pathways. So, you know, it was very much on based on the lived experience. So I guess the process here in terms of what was done was the Rare Diseases Office was started with the clinical expertise to get a broad brush. What do we think the pathway might look like or should look like from the clinical perspective? And then we gave it off to the patients and the patient organizations. And some of them spent weeks, some of them spent months. Some of the pathways might have had 2 or 3 inputs. Some of the pathways, they might have had, you know, a couple of meetings with 8 or 10 of them discussing it. So it was a wide variation in terms of how the input was gathered. And that's really just, I guess, the capacity of the individual organizations as well. But what I would say is, maybe in contrast to what Matt was speaking about just there, is that this was led from inside the HSE. And I know I've spoken with some organizations in the UK where they're quite envious of the fact that we have somebody inside the system that is navigating the system for us. We haven't had to identify who are the approvers, how do we get it approved, who needs to be involved in all of these different meetings. So it's, you know, I guess we're lucky in that regard, but there's still a lot of work to do. So where are we at this stage? So of the 30 or so pathways, 11 have been signed off at a national level. So they have received, I guess, what our healthcare services called the HSE, the Health Service Executive. They have received that national approval. 20 pathways are still processing through. So this is 4 years later. So it's a lot of work. There's a lot of, I guess, pushing, continuous pushing to get this done. And then the next step is obviously commissioning. So it's all well and good having pathways approved, but nothing happens unless people actively go out and, I guess, bring the pathways to life in the clinics and on the ground, and in the communities. And that is the stage that we're at the moment. We're still seeking funding for commissioning of the first couple of pathways. We hopefully will have something, I guess, in the next budget, which will come up towards the end of this year in Ireland. So what did we learn from people living with rare diseases, from the patient organizations? The common needs across pathways: coordinated care, holistic care, psychological support. Psychological support was across every single pathway, and I think came as a bit of a surprise to maybe some within the healthcare system, that they felt that, you know, we're providing this to our patients. You know, me being the expert in a disease is providing it to the patients, but actually there was a lot more demand for psychological supports than the system currently provides. And then timely access to, I guess, all of the healthcare practitioners right across the system, be it from the expert providing a diagnosis to your speech and language therapist in your community. We have a lot of challenges, I guess, with delays in accessing care, generally speaking. And you know, I guess the other piece that did come through as well was the core roles across all the pathways. You know, a nurse specialist, a psychologist, as I mentioned, medical social workers, database managers, and we don't even have electronic health records in Ireland. So, you know, we have a lot of catching up to do, let's put it that way. And certainly we're a long way from registries and things like that, which would obviously help to develop and improve the healthcare service, generally speaking. And then finally, health and social care professionals out in the community. So I guess a lot of this was very, you know, when you looked at the input from the 25 or 30 so different pathways, you know, these are the things that were common across the pathways and really helped to highlight, I guess, the need to move from focusing on an expert hospital-based care system into a more holistic care system. And that was really, I guess, the advantage of bringing the patient voice into the development. Happy to answer any questions and to get involved in the discussion. Thank you.
Thank you, Vicky. It's, you know, hearing you speak after Bradley, I'm really struck by both of you. The outcome of the pathway was really a shift from being this sort of expert centre-led service to one which is more integrated into sort of community or different, you know, it's more accessible locally. So that shift for you from that hospital base to a holistic approach, connecting more further out, and the same with Bradley in terms of that extra tier. I'm wondering whether that would be a theme which would come out of the work we'll be doing on the joint action, is thinking through that how do we connect ERN pathways locally? Is it that we need the bridge in between local experts with more specialists, whether they're national or European? I think this really brings me nicely to Ilyara and thinking about, how European pathways can help shape, national pathways and to inform local care.
Yes, thank you, Matt. Thank you, everyone. And yeah, absolutely. I think that the patient care pathways are the first step to integrate the ERNs into the national systems, because it's a daily procedure. And this is what we thought within ERN Reconnect, which I'm part of as EPAD, when we started working on our patient care pathway on systemic sclerosis. This is the reason why ERN Reconnect has developed an organizational model, including also experts in health economics, because these patient care pathways must be sustainable by the health systems. They must, as someone already said, be part of our daily life. We need them to become reality for patients that are brought and led through their experience of living with a rare disease, but also for the clinicians, as well as for the general system. And we starting to understand the discrepancy around Europe, because we can't think that what is needed in Norway, for example, or in England is the same of what is needed in Cyprus or Italy, because of different situations, because, as Vicky said, of the lack of experts in a small country like Ireland or like Cyprus. In Cyprus, when we made a survey and analyzed the answers, were really missing very, very basic treatments. And in Norway, that's why I brought these two specific examples, they were lacking warm clothes, because cold temperatures are not in favor of systemic sclerosis. That is the disease that has been investigated. So we really needed to know all these unmet needs and to start working on this and try to fill the gaps that were existing. And then we, based on the answers, we built other questions and asked our patients through FESCA, the European Federation of Systemic Sclerosis, to ask the patient and give their experience an open question. So it's the mean of narrative medicine, asking them to let us know what is facing with the disease and with the healthcare system. And these stories, a huge number, have been analyzed by experts of narrative medicine and made available to all the stakeholders that have been involved, like, for example, a general manager of the hospital. We really needed his input and see if what we were asking is feasible or not in an expert center belonging to the ERN. As already been said by Matt, the healthcare system, the patient care pathways are plans that should guide throughout the time. So there are different stages, and what we were missing it was the first actor, which is the GP, because usually when you feel experience a symptom or you see a sign, in our case is a renal phenomenon, you approach the GP that is supposed to refer you to an expert center. But nonetheless, we were a multi-professional and multi-dimension group. With this, I mean that patient care pathways are not written in the stone. They are a work in progress and they should be updated. This is what we members of systemic sclerosis disease working group think, that we have discussed this and found a consensus when in February 2020, just the day before of the pandemic. The pandemic, of course, changed all our projects, all our programs, as for everyone. And we have to postpone the pilot phase. But as said, it is a work in progress. And we need to update it with the nurses, different kind of nurses. But again, in some countries, we have rheumatology nurses, expert on the disease. In others, as emerged from the survey through patients, nurses just to heal some digital ulcers are not existing. Psychologists, rehabilitation, physiotherapy, dietists. And I think that Matt and Ines and Andrea as well, we should have a repository of the patient care pathways, because what Bradley showed before, it's absolutely important in our disease. So instead of reinventing the wheel, we could take something that you, Bradley, in the UK have already developed on ILDs and integrate the patient care pathways of another disease that experience the condition. As well as Vicky showed, they already work on Ehlers-Danlos syndromes. So ERN Reconnect could use the experience made. But anyway, I think that what Reconnect has done very well is the involvement of patient EPAGs, patient advocates that went back through to the community and asked the community to fill the surveys, to give the patient experience, as well as they were active during the consensus meeting, the last face-to-face meeting of Reconnect before the pandemic, in shaping the patient care pathway, including, for example, the consultation with the psychologist since the diagnosis, which doesn't happen usually. This specialist in some countries is not present and is not paid by the health system. All these kind of consultations, like the rehabilitation or nutritionist, are costs out of pocket for patients. So yeah, I think we've made a great job. We just need to update it, also considering the important learnings coming from the COVID experience. So thank you. And I will be happy to answer any questions from your side.
Thank you very much, Iliara. I just want to ask people, there's a few questions in the chat. I don't know, Ines, whether we could post Bradley and Vicky and Iliara so we can see them when we ask the questions. There's some questions in the chat, but I just want to go back to maybe Iliara first. I haven't quite understood, even though I've listened a few times and I've read the articles which are on Reconnect's website, which are also very good. You talk about your pathways being organizational pathways as opposed to clinical. Maybe you could just separate, distinguish what you mean. What's the difference? Just so I can get clarity, really.
Yeah, of course, they are clinical pathways because clinicians discussed and found clinicians and patients discussed and found a consensus on the best patient care pathways. Nonetheless, the model at the origin of the pathway has been developed also with the support of the National Rare Disease Center, of experts in health economics, of general managers of hospitals. This is the reason, because the model must become reality and must include the perspectives of different stakeholders, including the payment, the decision makers and the payers.
Super. That's really good to understand. So they weren't clinicians and patient representatives sat dreaming what would be great. You were trying to put your feet on the ground. Maybe Bradley, you talked about bringing that multi-stakeholder group together. Were yours also a bit structured in that way, i.e. the more they did consider about the implementation aspect or the constraints of your system? How is that similar?
Yeah, I would say everything we've done has been built out of frustration at the constraints of the system. So I think there was a general agreement that the current system is not fit for purpose. It hasn't been necessarily designed with demand or capacity in mind. Like a lot of specialist services, it's sprung up out of need and then interested parties, and the centres were then designed around that. And although prevalence and new diagnoses are growing, or at least we're better at diagnosing people and seeing more diagnoses come through, the capacity isn't growing at the same rate, or really hasn't grown at all in many cases. And that's where part of the disparities around the country come from as well. So making sure that we had national commissioners, regional commissioners, local commissioners, the people that are designing these services and understand how the system could be rearranged was absolutely essential in designing something that was, I guess, a vision, but realistic in potentially being implemented.
And just Vicky, your approach, you were saying actually Bradley had to work hard, and the ILD community worked hard to make sure that those people in power, the responsible ones, were involved in the process. But for you had those people leading the work, really. So, or was there challenges for you as well to get these pathways owned for implementation?
Yeah, well, okay. So I guess we had, HSE management, so an administrative area leading on it. So clearly you had to get the buy-in from the clinical leads as well to actually to get on board with it, and that hasn't always been successful. There has been pushback from some of the clinical leads on some of the pathways. So I guess it's a mixed bag of responses, as is anything when you're dealing with people. And then for those that have made it through the system, and I would say the biggest advantage of having this being an internal process as opposed to an external one is knowing how to navigate the system to get the system the signing authorities, I guess, at the top levels of the system. And everything seems to run up to the very top almost of our healthcare service, and then gets approved right up at the very top. It's not doesn't get approved at a level that I think a lot of this stuff should happen at. And so I wouldn't know how to navigate that. It's only because we have people internal to the system that actually know there's these strange acronym groups that do this thing every couple of weeks. They meet and they make decisions on these types of things. So that was important. The commissioning, as I said, is still still up in the air. You know, it's all well and good. We have these, we have a website with 11 lovely looking documents on them, hosted on the by the HSE, but we still have no commissioning of them. So, you know, that's still the next step. And I guess that's where we as patient organizations are now trying to put pressure on the government to make sure that this does actually happen, that they provide the support to get this over the line. As I said, you know, we're in the middle of a transition in terms of how the healthcare system is set up. We've literally, we every couple of years we seem to throw everything out and we'll start again and try and rebuild this Titanic that is slowly sinking. And so we're in the process of doing that at the moment. And, you know, I guess there is more political backing for rare diseases at the moment than there was historically. So I'm hoping that we can get some of this over the line and use some of these pathways to demonstrate how the new system can work with the pathways. I know that there's lots of Irish people on this call who'd be very frustrated to hear that, you know, implementation is of course the challenge.
And Iliara, maybe, you know, you have you made that next step into implementation or are you still trying to figure out how to do that?
Yeah, we didn't start the implementation, but maybe before doing it, as we have noticed that some crucial professional were not included in the first, we can also consider to include them, update the pathway, and then implementing it. Okay. Maybe conducting another survey or the same survey and analyze. This is just my personal opinion about the survey, and analyze the results, comparing them after 4 years. Maybe also we can have improvements after the pandemic. Why not? I'm not negative. I'm always positive. So I think we should focus on what COVID taught, and also teleconsultations in some fragile patients. Maybe they have become a reality, and I can make this pathway even smoother. Okay, so let's see what the discussion within my disease group and within Reconnect will lead.
Okay. Ines, you've got your hand up. You want to ask a question?
Yeah, no, it's to ask the questions from the audience. We have a couple of questions. So first one is from Jamie from the Netherlands, and she or he, I'm not sure, is wondering whether there is an overview somewhere of care pathways that have been completed in the different countries, whether there is a mapping.
But I don't know. Does anyone on the panel know? For your disease conditions you represent, I'm not aware of that they're really accessible.
Me neither.
I mean, the ones in Ireland are available on the HSE's website, but you know it extends to 11 pathways at the moment.
Okay, so in the joint action, we're possibly doing between 10 and 14 pathways in the next couple of years. That feels quite ambitious. So I think that's a take-home message. I know that Vascular have some pathways, Gentoris does as well, and Reconnect, but I think I'm not really. No, I don't think there's anyone anymore. So yes, I think it may be Jamie. If you could share the link with the pathways you've got in the Netherlands, that would be great as a starting point. And Ines, maybe it's something we can engage with the national alliances on.
Okay. Yep.
There's another question, Iliara.
This is just I'm thinking loud. Sometimes it would be more interesting to develop first patient journeys and see really what patients are going through, and based on that, shaping the patient care pathways.
Yeah,
because sometimes the journey is even more complicated than we think.
No, that is something we plan to do with the work under JARDIN. And I heard, and I'll come back to it in a minute, about there was some consistent approaches you all three were taking involving patients, and I just would like to pull that to the surface before the end of the webinar. Ines, is a couple of the questions.
Yes, well, there is a comment from Lindsay Walsh from Ireland, which resonates a bit with what Vicky has said about implementation. So she's just saying that there is no central hub or central for rare conditions in Ireland. So the opportunity to support and inform new regional health areas and care in the community at a regional and local level will still be a postcode and condition lottery. So, well, we still have a lot to do in Ireland. And then there's a question for Bradley on whether you've incorporated shared decision-making into your care pathway.
This should be a fairly straightforward one. So just to be clear with everyone, so shared decision-making is about putting clinician and patients' voices on level footing, making sure they collaborate around treatment decisions, care decisions, but also enabling, upskilling of or education for patients to make sure they are informed to be able to make decisions that they need to. So with the pathway, the very simple answer is no, but purely because we are looking at system change only. So we've had to be quite strict in the remit for this because there was initially quite a lot of scope creep, and we are focused on the I guess the NHS systems and the way in which they interact and the way and the capacity and changes there. However, all of this is built around the patient demand for how they want their services to look. So we're going partway there in trying to set up a system that enables shared decision making and enables care and decisions to be made in the appropriate location. But we've not gone as far, and purposefully not gone as far, as making decisions around shared decision making, clinical decisions, which treatments to give when and where, and all those kind of areas, but rather setting up the system to be able to do that adequately. So sorry, I can't be of more help there.
No, that's fine. You answered the question. And there's a question from me actually also, maybe on scope creeping, Bradley. So I wonder whether you've mapped the capacities of expert centers that the expert centers need to have to deliver adequate care, and whether you've spelled them out in the care pathway or in any accompanying document.
Yes, so this, is the elephant in the room. And as I mentioned, a lot of the way in which these centres have been set up is kind of historic interest and trying to build that out and make sure that there is some provision for this specialised care for rare disease, some in the local area, but it's not always the best case, and there isn't the capacity as needed. So there've been a couple of documents that have helped and some that have perhaps slightly hindered our chances with this, but we are helping services to be able to audit their capacity and resource at the moment, to see how many patients they are seeing a month, how many are new patient appointments, how many are follow-ups, how long they've had to wait to get there, to kind of show the demand in the system. How many people are on antifibrotic drugs, how much monitoring is required for that, how many of those appointments that are follow-ups are set around monitoring, and then mapping that against their existing capacity. Unfortunately, a lot of the business cases that we try to put forward to increase that capacity is looking at other centres and saying we are worse than an equivalent sized hospital trying to deliver the same care, rather than thinking about what is actually the best standard available, or that we should be providing for these patients to make sure that they have access to care in a timely and equitable fashion. There are some estimations of those numbers, and they are not necessarily in line with what we'd like to see, but more about what's realistic for the healthcare system. So they don't have the capacity, to answer your question quite squarely, and we've set out kind of expertise required within centres to be able to prescribe or diagnose, but not necessarily how many people within that, and we're leaving that down to the clinical community and helping them to come up with those numbers. And sorry, Ilaria had a hand up as well through that.
Iliara? I didn't know whether you whether you wanted to contribute. I didn't know if you're in a cafe and you're asking for a nice cappuccino. Oh, sorry, an espresso because it's after midday.
Of course, espresso. No, I was not asking anything. But no, again, for the update, it's not related with what Bradley said. We have also to consider that when existing, clinical practice guidelines are updated and new drugs are approved for some rare diseases. So again, to keep these pathways open and as a work in progress, in my opinion, is crucial. Otherwise, we risk to keep them, let's say, like in a box. But I saw you, Bradley. I think you don't share what I said, and if not, I really would like to know.
Sorry, Ilaria, I lost you at the end there, so I don't know what the question was.
No, if you don't agree, I really would like to know.
Oh, no, I think I did agree.
Okay. No, because I like to hear from people that have a different opinion.
So I think, you know, we part of the implementation isn't to assess, like in Ireland, okay, we've got these, we put them in place and put the resources there to have those extra, a coordinator, access to psychosocial care, etc., etc. But the implementation is, as Iliara said, is an open thing that there's a mechanism there to monitor, is this effective? Is this delivering the outcomes we expect? And reporting that how these pathways are running in reality to review them on a periodical basis, to update them. I think that feedback loop is really, really key, and it's one of the things I'm pushing in the joint action. Whilst let's say we develop 12 pathways in the next 2 years, part of that work package is then taking them and piloting them and coming up with some recommendations for each member states of how to take these pathways and implement them. And so I've got my mind's eye on what are the recommendations we need to be saying to member states, and we need that in that recommendations, this feedback loop from local centres back to the ERNs to say, these pathways are working, they're not working in this situation. So I think the joint action is really about almost hooking the caravan on the car, you know, connecting local systems with the ERNs. And I think that's one of the key outcomes in my mind from the joint action, and they're not something to be reviewed at one point and then left. They're live situations. Whenever you hit a hospital, whenever you hit a clinical service, you're on a pathway. The question is that pathway evidence-based? Well, it's probably based on the capacities the service had at that point in time, and we might be missing that psychosocial support, and et cetera, et cetera. So the governance on this is really, really key.
And data collection, I think standardized questions, if you're going to be looking at it across different countries, trying to understand what you want to get out there, because I mean, rare disease data collection in the UK is not fantastic. For pulmonary fibrosis and ILD, coding just to understand how many people are diagnosed or living with the disease is not very good. And I don't want to make assumptions usually about anyone else, but I don't imagine it's too fantastic across a lot of other countries either. So how can we monitor those outcomes? How can we understand what we want the pathways to be achieving, and how can we implement those data structures and that regular data collection and reporting to be able to do that? I think that's sorry, Matt, that's a
no. I think it's really good. But you know, with gene and cell therapies which come on and are approved and get early approval, you know, they put in some requirements to collect data ongoing, and health systems struggle to do that. So there comes a cost with that monitoring side, which needs to be built in. Otherwise, you know, we don't ever know that what's been implemented has been implemented. We don't know whether it's achieving what it's supposed to be achieving, and we never really move forward. I would like to ask all three of you, just winding back to the development of your pathway, what do you consider is the best practice methodology for involving patients in the design of a care pathway? Maybe, you know, if we start with the bit around scoping needs, I heard from, I think it was from Bradley and also from actually from all three of you, was that you look at doing identifying needs and using some form of survey, and also doing some workshops with people in the community. Is that as good as it gets? You know, is there other bits which are missing? Bradley, you highlighted about one-to-one interviews. What was that something you considered actually was really beneficial? I didn't hear that necessarily with in Ireland or with Reconnect. Is the interview bit something which we should be pushing for as part of that methodology?
Yeah, I'll jump in, I guess. Yeah, I mean, I think it is really important. I think we have to, I mean, when you're trying to think about how you're going to make this pathway happen, you have to think about how can I equip myself with all of the tools that I need to be able to show that it's evidence-based, but also persuade the decision makers that they should be focusing on this, so they should be putting their limited resources behind this pathway and not be looking at other conditions. And part of that is trying to really demonstrate the unmet need. And you can do that through a survey, and you can do it through the focus groups, but that will give you the kind of common denominator. But there are significant factors that affect access to care that are beyond those common factors. So for us, it's we've seen a paper published recently that shows that deprivation is linked to poorer outcomes in idiopathic pulmonary fibrosis, and how far you live from a specialist center can affect your outcome as well. It could be about access to information for people who are who don't have English as their first language, or speak very limited English, people who've got quite unique journeys in terms of their transgender journey, or other kind of psychosocial issues that have come up. So trying to make sure that we are covering those bases and making sure that those voices are heard, I think, is really important, and helps to give you a kind of full data set and a full picture of where you need to be focusing your time and energy.
Super. I don't know, Vicky or Iliara, the methodology for involving patients for you, what really worked, and where after developing your pathways, is there any insights you've got that actually you wish you had done something else, or there was something else you would like to add in the future?
I think, you know, I think we've got to be careful that we don't over-engineer it.
Mm-hmm.
You know, certainly in Ireland the situation is sufficiently shambolic that anything is better than what we have now. So I don't know if shambolic is a word that translates into other languages, but it's sufficiently messy.
Let's call it this room for improvement.
Yes, yeah. Definitely. And so I am like, I think, you know, I guess the patient needs assessment and things like that, they're all great to have, but I wouldn't say we must have it before we start on the next step. I think we just need to get going with all of this stuff. There are 6,000 plus rare diseases at the moment. I can guarantee to you we will never have 6,000 care pathways. It's just not practical. And so we need to find ways of, I guess, developing example care pathways and plugging in other conditions around them. That, you know, everybody would like a defined care pathway for their individual disease, but healthcare systems just won't ever have the capacity to be able to do the desk work that's required to define all of these care pathways. And we need to get ourselves 80% of the way there, and be able to start plugging things in. So I think that we need to be very, I guess, creative in how we think about doing this job. And the work of JARDIN, and I know that some of it's based in Ireland, and I'd be quite strong in terms of, how do we make sure, when I look at, I guess, what came back from the patient community across 30 pathways, and the unanimity around psychosocial supports or access to care in the community, speech and language, OT, those types of things. It's kind of like, do I need another 100 care pathways to tell me I just need to do this? I need to put in place the community-based care systems for the rare disease community. And the challenge, I guess, that we have here, and Bradley talking there about electronic health records, and we're so far from it. We use a rule of thumb, kind of like the 1 in 17, 300,000. We have no idea how many people in the country are living with rare diseases, none whatsoever. We do not count anybody. I mean, like the omni shambles, the mess that happened when COVID hit, and suddenly our expert clinicians were having to go through paper records and find who should be getting a COVID vaccine first, who are those critical patients, because there was nothing at all. And so it's trying to, I guess, move all of this forward in Ireland and bring in a couple of really good examples of care pathways, and then kind of like say, right, we need to plug in. And I think back to what Lindsay Walsh was saying there in terms of, I guess, rare disease centres. From our perspective, as we're in the process of developing a new national strategy on top of all of the rest of the stuff, that is certainly one of those things we need to look at, is can we have expert centres around the country that can at least enable that community care? We know that the expert clinician maybe is going to be living in Dublin, or is based in a hospital in Dublin, or based in a hospital somewhere in Europe for that really specific expertise. But there should be other ways of doing this. And I think, this is hopefully part of what JARDIN will throw up as a small country. This is how it needs to be done in a small country, And Ilaria, just back to the EDS and Reconnect. We don't even have Reconnect in Ireland. It doesn't exist yet because we haven't been able to get the clinicians to agree who would be leading out on it. And so, I think there's still lots of things to do, but anyway, that's so I think, the patients, Irish patients, are always willing and able to voice their opinions, and people do get involved, but I guess there's a whole systems piece as well, because I really don't want to go down the route of generating lots of I guess the needs, patient needs, and at the outset, and then discovering actually none of this is going to happen.
Well,
it's expectations management, I guess, is part of it as well.
I think what I learned from the Irish approach was, there is a generic pathway for rare conditions, and if you're from a primary care perspective, actually you just need to know what are the red flags to, what are the things to move people on to someone who might know.
Yeah.
And those senses. I love the idea of enabling community care, that's sort of connecting with a bigger, where people are locally, which I think what they're doing with the ILD. I think, just before I come to you, Laura, I think there was one point, Bradley, you had highlighted in being a native Brit. It resonates with me. I understand it, but I don't think other people might necessarily understand it. And it was something called shared care arrangements. What your pathway does is have shared care from a specialist centre with a local centre, i.e. a community care model. And those shared care arrangements are really where what can be devolved from a specialist centre to a local centre, what can be done, and having an agreement between those two centres that, okay, we will send this person to you for the follow-up, and you will do X, Y, and Z. So I think that shared care arrangements, which is an agreement, is something which I'm not quite sure is well known and understood across the EU, but I think is quite an important aspect to support a pathway of care. So I just wanted to pull that out. I don't know whether you want to add something.
Yeah, coming in on that, I think, yeah, absolutely. It's a really important area if you're looking to consider care in a more holistic fashion, and you're not thinking about that kind of strict delineation between primary, secondary, tertiary, and community care. It's also part of my presentation, and I think the biggest success that we've had is around using the priorities of the people, I guess the changes within health system structure, and Vicky touched on it as well. We've seen the kind of the changes to commissioning in the UK, well, in England recently, which gives single bodies responsibility over kind of end-to-end journeys of care. And that's real, and using those priorities and those changes has really enabled us to pull the political levers that we've needed to make some of this happen. I think without those changes and without a real focus from commissioners in the health service on moving from the old system to what we currently have, a lot of this wouldn't be available. So you've really got to understand where are the movements happening, what pressures are being put on the senior people by even their bosses, what are the wider structural changes that might be happening within your health service, and how can you really make the most of those and kind of fit into those priorities.
Thank you. Iliara, coming back to you about patient involvement in the process, you talked a bit about narrative medicine and stories. Maybe you could shed a bit more light on what the principles of narrative medicine are, and how that has been key to making your the involvement of patients in center stage.
Yes, sure, Matthew. Narrative medicine basically collects and analyzes what patients decide to share in writing their stories, writing the experience on something. Of course, this depends on the question that is asked. And what we ask is to share their experience in coping day after day with the disease and the healthcare system. And it was really interesting because despite the country they were based on, they all had the same experience of fear, of anxiety, of the future, and the relation with the clinician. So this is quite interesting. Then they went beyond, of course, explaining their relation with the difficulties in getting exams in time, feeling lost in their relation with the system. But when you ask if the in-depth analysis could be added, I think so. I think yes, because we are all working not to leave anyone behind. And the person we left behind, I think, the first generation of migrants that do not understand even our language, and they feel really lost in this complicated world of health. And I think that the specific interviews in their own language could help us in better shaping patient pathways. Because I see during the hospital's medication that they need an interpreter that usually is the son or daughter, but these are delicate moments and nothing must be lost in translation. So also maybe considering some cultural barriers in performing some evaluations, some tests, the gender of the doctor, if in their culture women are not allowed to have a consultation with a male. I believe we need to keep all these things into consideration. And the in-depth analysis would help them really share without any prejudice, without any limitation of the language barrier. what they are really facing in their daily lives.
Thank you, Iliara. Ines, you've got your hand up because I know there's some more questions in the chat.
Yeah, there's no time
to.
left, so I don't
There is
know.
a little bit of time left.
Okay, so, well, first of all, just to say that what Bradley said about having a budget from the beginning until the end is a massive thing. So maybe JARDIN 2, let's say, after the 3 years, we would need to see how to, how the care pathways that you will develop in JARDIN will kind of lead to those changes in the way services are commissioned because if you don't have that change, implementation is going to be very difficult. So if the budgets are fragmented, the implementation of the care pathway, even if it looks lovely in paper, it's going to be very, very complicated. So, so 2 questions. Monica Racoita says, if care pathways is such a beautiful and useful tools, why is it that we don't have lots of them in throughout Europe? Are there any reasons why countries haven't developed them, or is it just, it's something that is country specific, and some countries have decided to have them and some have decided not to have them? And then there's another question from Patricia Martin saying that, yeah, since most rare diseases are diagnosed during childhood, in your opinion, which patient reps provide the best feedback for the development of the care pathways, adults, their caregivers, a mix of both?
I don't know who wants to answer the question from Patricia first.
I can maybe try to give an answer based on the Italian experience. We have actually 20 health systems, 1 per region, and each region has the autonomy to decide how to spend the money. So we went with our organization to Rome, to the parliament, and I asked, why having 20 different patient care for the same disease? It's a nonsense. Of course, the politician agreed with me, but the reality is that the reason is politics. In Italy, expert centers are designated on a regional basis without real clear evidence data. The general managers are nominated by politicians. So in Italy, there is not the will to make and harmonize patient care therapy for all the regions, 1 per disease. This is the Italian way of managing things. And I don't think that things will change in the future, but at least all patient organizations are aligned that this is not the way, what we need.
I think, Iliara, for me, the work like Bradley's highlighted from the UK, I think what developing the pathway for for your condition was it empowers the patient community to look for and to advocate what's needed for them. And I think that's also a very valuable thing. So in an Italian system, you might not get the systems to be aligned, but you can at least try and get set expectations on what good should look like and empower the tools the pathway can empower individuals and their families to reach that. This other question which we had was around since most rare diseases are diagnosed during childhood, in your opinion, which of the patient representatives should provide best feedback for the development of care pathways, adults, patients, or their caregivers, or a mix?
I'm happy to jump in there.
Yeah.
I think you need a mix. I guess people that have lived the experience and walked the journey will have one perspective. in terms of, you know, being diagnosed themselves with a rare disease will have one perspective, and then family members and parents and guardians and carers will have a different view of the world. So I think that you do need both to be there, but obviously, particularly when it does involve children, it is I guess it's an all hands on deck type scenario. You know, I've seen stuff recently, which I think actually came out of the Aurortis newborn screening survey, you know, where you had people regretting a diagnosis as a child because they felt that it took over the entire family. You know, and so I think, you know, you do need all of those voices in there. But it's, you know, it's not easy. I guess take whatever voices you can to start with, and then try and expand on it afterwards, but don't, I guess, as they say, don't over engineer it from the outset.
Brilliant. I'm going to stop us there, and Iliara, just because we've just over time now, and I want to respect people's diary. I want to say thank you very much to the three of you, to Vicky, Iliara, and Bradley for, you know, taking part in the webinar, sharing your experiences developing pathways. We can see that they're all different, but actually there's some common approaches which are being adopted, and we'll continue to work with the patient community on building that model into JARDIN. So thank you very much for everyone joining today. There is a survey, which I don't know whether we've posted already. I'll just put it on screen so you can have a quick look. If you can complete the survey, that would be really great. There's a QR code because we're now fancy. Thank you very much, Nora, for that. Yeah, we will follow up with this. The next steps for this webinar is we're going to work with some of the patient representatives in the ERNs to develop the toolkit, look at the methodology in more detail of where patient representatives should be involved, and develop the toolkit based on that. And we'll draw from this workshop as this webinar as well. So thank you very much, and thank you for completing the survey. Thank you. Bye. Thanks, Andrea, for your support.
Bye. Thank
Nora.
you.